Good evening, everybody. We are on the third Wednesday of May. We'll start the ASI time this Wednesday with a very important topic, which is very prevalent in India: abdominal tuberculosis. Um, can I have uh, Dr. Pratap Singh Varade to make the opening remarks?
Thank you very much, Santosh sir. Respected President ASI, Dr. Murada Pandian, immediate past President, Dr. Praveen Suryavanshi, Honorary Secretary, Dr. Gaddi Diwakar, Honorary Treasurer, Dr. Madhumita Mukhopadhyay, Director Academic Council, Professor Dr. Rajgopal Shanwai sir, Convener International Affairs, past President ASI, Dr. Prabol Neogi sir, the Chief Architect of ASI Academics, Advisor to ASI, past President ASI, Dr. Santosh John Abraham, sir. It gives me immense pleasure to welcome today's faculties as well as the viewers on the ASI YouTube channel for another interesting session at ASI Academics, the theme being the abdominal tuberculosis. The government of India has already undertaken the TB elimination program in 2025 and global target being 2030. We have found decline in the incidence of tuberculosis by 16% and TB deaths by 18% from 2015 to 2023. But still, India is the highest burden of tuberculosis in the whole world, accounting for 27% of the global incidence. Abdominal tuberculosis is also called as a great masquerader, as it continues to test our clinical judgment with its varied presentation and management challenges. From acute abdomen to chronic abdominal pain, from obstruction to perforation, it can present in any form. And today we are privileged to learn from the distinguished experts who will help us navigate these nuances in this complex disease. The panelists being Dr. Hemanthi R. from Kakinada, Dr. Ajay Thakrar from New Delhi, Dr. Albail Singh Yadav from Jhansi, and Dr. Preeti SP from Mysuru. And the icing on the cake, being the entire program will be moderated by the veteran teacher, Professor and Head Department of General Surgery, Northeastern Indira Gandhi Regional Institute, Health and Medical Sciences, Shillong, Dr. Noor Totro sir. So without further ado, I welcome you all once again and looking forward for the wonderful session ahead. Thank you very much, sir.
Thank you very much, Dr. Varade. Now over to Dr. Noor Totro for taking this subject.
Thank you, sir. I've shared my slides. Are they visible, sir?
Visible, very much.
Right.
Okay.
So I think very rightly pointed out about the impact of abdominal tuberculosis and tuberculosis in general that we have in this country. Roughly about 1 to 3% of all TBs end up being abdominal tuberculosis. And when you talk about extrapulmonary tuberculosis, about 6 to 13% end up being abdominal tuberculosis. Being a possible bacillary and multi-organ involvement, diagnosis is quite a challenge. And like rightly said by the earlier speaker, it's a great mimic. And therefore, diagnosis is a challenge. Newer molecular assays have given a fresh lease of life to diagnosis and detecting of drug resistance, which has become a very common problem today. Again, another burden that we have today is the immunocompromised states, which we very commonly see because of certain disease states, and treatment becomes very challenging. Surgery, from a surgical point of view, as surgeons, yes, it has a definitive role, but yes, it is very limited. My speakers have already been introduced. The first speaker will be speaking on the etiology and classification. The second speaker will be speaking on clinical features and complications. The third speaker will be talking about the diagnostic dilemma and the difficulties that we have in diagnosis. The fourth speaker will be speaking on management and specifically the surgical aspect, and to some extent, the outline of what is the national recommendation regarding the medical treatment. And I have been introduced already. Thank you, sir. So the basic rules will be, I'll be handling all the PPTs. The speaker may kindly prompt me verbally to move the slide back or forth. Question and answers will be at the end of the presentation. Speakers may answer the relevant area questions, and comments from the ASI organizing team, which is there, is definitely very, very welcome. So welcome to the ASI webinar on abdominal tuberculosis, a very common and a very important problem that we confront day to day in our surgical practice. The first speaker, Dr. Ajay Thakral, may kindly take over.
Dr. Ajay, sir, unmute, sir.
Dr. Ajay?
Sir, unmute yourself, sir. Yes.
Thank you.
Yes.
Good evening, everyone. So I'm Dr. Ajay, and topic allotted to me is related to etiology and classification of the abdominal tuberculosis. Basically, this disease is no doubt very much prevalent and in India. And if you'll see the disease part, still it is very less. But if you'll talk about the infection, so it is very much prevalent. So I think every clinician, every physician, they must know about the complexity of this disease. So I'll start with the etiology. So we normally know about this Mycobacterium tuberculosis is the causative factor of this disease. But it's not only the Mycobacterium tuberculosis. It is basically a complex of many bacteria which are basically related to this Mycobacterium tuberculosis, like Mycobacterium tuberculosis, Mycobacterium bovis, Mycobacterium africanum, Mycobacterium microceae, Mycobacterium caneti. So there are many bacteria which are associated in the etiology of this Mycobacterium tuberculosis. There are certain other type of non-tuberculous mycobacteria also which we have to handle during our practice, like Mycobacterium avium complex, Canaceae, and Fortiums. So basically, they are important in the post-op infections, implant infection, chronic sinus formation. They are typically different from the Mycobacterium tuberculosis. So if we'll talk about the risk factors in India, so their risk factors in India is basically related to social determinants, medical risk factors, and nutritional aspect. So I'll start with the social determinants. It's related to the poverty, malnutrition, overcrowding, poor ventilation, illiteracy, delayed healthcare access. So all these factors are associated with increased incidence of the tuberculosis. So if we'll talk about medical risk factors, they are associated like HIV infections, diabetes mellitus, smoking, alcoholism, immunosuppression, chronic kidney diseases, malignancy. Everything is related to decrease in the immunity of that particular person, and ultimately the latent infection will flourish into the main disease or active infection in that. And other aspect is the nutritional aspect. It is also the relationship between the tuberculosis and the malnutrition. So malnutrition predisposed to the tuberculosis, it worsens the outcome, but TB itself causes weight loss and cachexia. So these factors are associated with the risk factor of the tuberculosis. One more term which is very important, the latent tubercular infection, as I already mentioned. So this infection is very much in the Indian community. So around 40% of the Indian community, 35 to 40% of Indian community is having latent infections. Once there is a decrease in the immunity, that there is an active infection in that particular person. So that is basically infection without any active disease, and they are common in the household contexts and the healthcare workers. And how we can do this microbiological confirmation of such type of things? So basically, we have few tests which we should, as a surgeon, should know: the Zn stains, Oromine, Rhodamine fluorescent stains. These are the things which can positively diagnose that yes, there is a tubercular infection. An important point in this AFB positivity in the abdominal tuberculosis is often low because of its extrapulmonary tuberculosis possibacillary. So there are two types of things. One is multibacillary and second is the possibacillary. The possibacillary means there is a less number of mycobacteria, so it is difficult to diagnose. So ultimately now we'll come to the this how to there are different kinds of gastrointestinal tuberculosis in India, which may involve the gastrointestinal tract, peritoneum, mesenteric lymph nodes, solid organs. So any part can be involved in the tuberculosis. It can be the intestinal tract, peritoneum, mesenteric nodes, and the solid organs. And how they reach the abdominal cavity, there is a route. So sometime whenever we'll ingest some contaminated food like the dairy products, milk, etc., so ultimately they will infect the intestinal gut. And secondly, through the pulmonary tuberculosis also. So the first one is the primary, second others are the secondary. Suppose there is a lymph node or there is some other source where there is a primary tuberculosis, ultimately that can reach the abdomen. So that can be through the lymphatic spread, through the hematogenous spread, or through the direct spread. So we can get the infection through the ingestion of the sputum from the pulmonary tuberculosis. So we can divide it into primary tuberculosis and a secondary tuberculosis. And sometimes we have to differentiate this tuberculosis with certain other diseases like malignancy, Crohn's disease, appendicular pathology, intestinal obstruction. So it is important to know how the tuberculosis behave, what are the clinical features and everything basis on that, and what type of workup we can do. So ultimately we have to differentiate tuberculosis from these diseases. Now I'll come to the classification of abdominal tuberculosis. This can be intestinal tuberculosis, which can be further divided into the ileocecal tuberculosis or ileal tuberculosis, peritoneal tuberculosis, which can further divided into acute peritoneal tuberculosis or the chronic peritoneal tuberculosis. And then there can be mesenteric lymph node tuberculosis, omental tuberculosis, solid organ tuberculosis like liver, spleen, and other organs. And there can be anorectal tuberculosis also. So we'll start with this ileocecal tuberculosis. It is basically involving the terminal ileum, the cecum, the ileocecal junction, and sometimes the ascending colon is involved in the ileocecal tuberculosis. And this ileocecal tuberculosis is basically of two types. One is the ulcerative type, second the hyperplastic, and third one is basically the mixed type. Then there will be ulcerative lesions also, and there will be hyperplastic lesions also. And if you'll see, ulcerative type is mostly after the secondary to the pulmonary tuberculosis. Patient will ingest the infected sputum, and it is more virulent, and it normally involves the terminal ileum and the common in the small bowel, and they have the transverse ulcers and mucosal edema is there. And if you see about the hyperplastic type, which is the primary tuberculosis, it is less virulent, bovine bacilli are there and common in the ileocecal region, producing a mass and thickening and mimics a carcinoma-like thing. This thing we have to differentiate from the malignancy. And sometimes there is a mixed picture also, ulcerohyperplastic type, which is a mixed lesion. Next slide. So this is a photograph which is showing how this ileocecal tuberculosis can look like. So if you'll see this cross section, the ascending colon is involved, the cecum is involved, the terminal ileum is involved, and there is a stricture is there. So it's a photograph related to hyperplastic tuberculosis. Next slide. And why is the ileocecal region commonly involved is a predisposing factor. It's a physiological stasis is there because of the wall. There's the abundant lymphoid tissue, Pierce patches are there, increased absorptive activities, and minimal digestive activities are there in the terminal ileum. That is why there are chances of more infection in that area. And if you'll see the ileal tuberculosis, it is basically the multiple ileal stricture, and sometimes there are jejunal strictures also, but more commonly they're in the ileal regions. Now come to the peritoneal tuberculosis. In the acute, there can be basically peritonitis. Typical features of acute abdomen, patient will have tenderness, rigidity, guarding, bowel sounds will be absent, and sometimes we have to differentiate with the perforation peritonitis or acute pancreatitis in such type of cases. And then if we see the chronic can have a gross ascites can be there, or there can be a loculated ascites, and sometimes there is no fluid. So that is called as dry plastic type, lot of adhesion, cocooning is there. And so there are two types of peritoneal tuberculosis. One is the wet tuberculosis and second is a dry tuberculosis. And last one is the purulent. Sometimes there is an infective foci, purulent fluid is there, like from the gynecological disorders, fallopian tube tuberculosis, that can lead to ultimately the purulent peritoneal tuberculosis.
Ajay, you have 1 more minute to go.
Yeah, sure, sir. I just one or two slides more.
Yes.
So peritoneal tuberculosis, you can have the picture. There's a thickening of the peritoneum, lot of tubercles are there, and there's a fluid also. So in this way, you can have a picture of this peritoneal tuberculosis. Next slide, sir. So like here, there's a mesenteric lymph nodes are there which are involved because of the tuberculosis. The omentum is also can sometimes be involved. There are calcified lesions are there in the omentum. So that's all from my side related to etiology and the classification of the abdominal tuberculosis.
Thank you, Dr. Ajay. You have timed yourself perfectly.
Thank you, sir.
Now the next speaker, Dr. Albail Singh Yadav. Take over, please.
Yeah, good evening all.
Good evening,
Thank
sir.
you, Santosh sir and Noor sir, for providing me this opportunity to speak on this topic. My topic is clinical features and complications of abdominal tuberculosis. Next, sir. Now, so the clinical presentation of abdominal tuberculosis is relatively very varied, and one has to have a very high index of suspicion to make the early diagnosis to prevent the morbidity and mortality of this disease. Now, it's basically a disease of young adults. It's commonly involving 20 to 40 years of age, but then any age can be affected by this disease. And usually the history is usually of weeks to months, but then again, one can have acute presentations also. So many of these patients can present with systemic features like low-grade fever, night sweats, anorexia, weight loss, failure to thrive in children, relative hypertension, and these non-specific features are mainly in ulcerative variety and peritoneal and lymph nodal variety. These specific features have a relative lack in GI involvement. And then again, 1/3 of these patients may have pulmonary involvement also. So then they can present with cough, chest pain, and dyspnea. And rarely one can have tubercular toxemia as a presentation. And these patients, they have very decreased immunity and have systemic features of shock at presentation, which is relatively rare. Now, as far as abdominal presentation is concerned, basically it depends on the site of the involvement. So the most common site being GI tract and the peritoneum, and the less commonly the lymph node. And rarely we can have solid organs also. Among the GI tract, the most common site, as told by previous speaker, is the terminal ileum and the ileocecal junction, which is mainly involving more than 80 to 90% of the patients. But then relatively less commonly involving the colon, the rectum, the stomach, and rarely the esophagus. Now, macroscopically, the GI involvement has three types: ulcerative, hypertrophic, structural, quickly moving. The ulcerative variety is seen in the early phase of the disease. It's basically caused by the rupture of the submucosal caseal granulomas. And these ulcers are transverse or circumferential ulcers in contrast to the longitudinal ulcers which are found in the Crohn's disease. And the presentation is with abdominal pain, diarrhea, and bleeding and malabsorption. And at this point in time, this variety has a differential diagnosis of all forms of colitis, which we think of, like ulcerative colitis, or it can be infective colitis as a differential diagnosis. Now, hyperplastic variety, the most common segment or the site is the ileocecal region. Now, the patients having this involvement is basically they have high clinical immune response, so which leads to the hypertrophy of the mucosa and the intestinal wall and forming a lump or a mass in the right iliac fossa. So then these patients presenting with a lump in the right iliac fossa has to be differentiated from other causes of the right iliac fossa lump, which include the cecal carcinoma, the lymphoma, and uncommonly the amoeboma the ileoceous abscess or the retroperitoneal lump. But then at the same time, with lump, they can also present with features of subacute or partial bowel obstruction also. So having clinically the colic abdominal pain, vomiting, distension, and constipation. And also sometimes, uncommonly, they can have acute on chronic or acute intestinal obstruction as a first episode. So then we have to take care of that. And the abdominal tuberculosis comprises about 20% of all cases of intestinal obstruction. Stitching variety occurs late in the phase, as in late phase of the disease, when the ulcers heal by cicatrization, when we give antitubercular therapy, or it is because of the host immunity. Now these ulcers, these strictures, they basically involve the terminal ileum or the jejunum, and then they can be single or multiple. And again, they present as features of partial bowel obstruction or subacute intestinal obstruction in the form of recurrent colicky pain, the distension, vomiting, gola formation, which moves from left to right, which can be seen also as well as palpated. And after admission, these patients, they either recover or sometimes they also require surgery. Next, sir. The peritoneal disease is this is most commonly affected in abdominal TB and maybe more common than GI in some medical series. The most common age is 3 to 4 decades, as told earlier, and more common in females because of spread from the fallopian tubes. Now, macroscopically, it has again of 4 types: wet, dry, fibrotic, purulent. The most common variety is wet type, which presents as ascites with peritoneal tubercles, and clinical presentations generalized abdominal pain, distension, low-grade fever. But then at the same time, we have to think of other causes of ascites, which are cirrhosis, nephrotic syndrome, CHF, and sometimes malignant ovarian tumors also. Why? Because if the patient has concomitant cirrhosis, then if we think of giving ATT, then this compounds the problem. So that's why it's very, very important to rule out these causes of ascites. The loculated variety presents as an abdominal lump, plus minus features of subacute obstruction. And this loculated variety has to be differentiated from other cystic lesions like mesenteric cyst, which moves at right angles to the line of mesentery, the ovarian cyst, which can be pulled out of the pelvis, and the retroperitoneal cyst, which is relatively non-mobile. The dry type involves the adhesions, which involve the mesentery, the bowel, the omentum, and these patients they present with non-specific abdominal pain and sometimes landing into obstruction off and on. And when they come, they have a doughy feel when you palpate them, or you can find a lump in the upper part of the abdomen because of rolled up omentum, or they can have distension also. And the fibrotic variety, in which the bowel loops, they become encapsulated in a fibrous membrane, more chronic variety, forming abdominal cocoon. Now, this cocoon can be partial cocoon or it can be complete cocoon. The partial cocoon means it covers only a part of the bowel, small bowel, while the complete cocoon means this encircles the small bowel as well as the large bowel. Although clinically presenting as abdominal lump or features of intestinal obstruction. So then at the same time, one has to differentiate from other causes of abdominal cocoon, which can be any catheter in the peritoneal cavity, which irritates the peritoneal cavity, can develop cocoon as a part and parcel of the chronicity. The ventriculoperitoneal shunt, prolonged usage of beta blockers, SLE, sarcoidosis, autoimmune diseases. It can be congenital also, or it can be rarely because of the retrograde menstruation. The purulent variety is nothing but when the ascites becomes secondarily infected, again more common in females because of translocation of the genital tract, or it can be from the rupture of the caseous lymph nodes. The presenting as abdominal pain, distension, ileus, these patients can develop interbowel abscesses, they can develop pelvic abscess, or can present as an umbilical fistula also. This peritoneal variety can also have acute presentations. And it can present as acute bacterial peritonitis, and then it has to be differentiated from other forms of peritonitis presenting as acute pain, tenderness, guarding, rigidity. So then one has to have all kinds of peritonitis at differentials. And also there are nodules on the peritoneum, the visceral parietal peritoneum on the bowel surface. And then one has to think also of nodules, which are there in the differential diagnosis like pancreatitis. They occur because of saponification of fat, the carcinoma peritonei, the hydatidosis, and the starch peritonitis. The nodules of carcinoma peritonei are relatively larger and they are more harder as compared to the nodules of the tuberculosis. Next, sir. The lymph nodes. The lymph node involvement is mainly in the small bowel mesentery, but then any lymph node inside the abdomen can be affected. The clinical presentation And sometimes these patients can have calcification on a skygram of the abdomen, and because of chronicity, and then they have to be differentiated from fecal with calculus or some foreign body. But then next, sir. But then the most common presentation, the periumbilical pain, and especially more common in children, non-specific abdominal pain is to differentiate from that because the clinical presentation is same. And later on, these lymph nodes, they become larger and conglomerate and forming mass in the periumbilical area. So this mass initially, when it is not fixed, can move at right angles to the mesenteric attachment, and later on it can become fixed also. And that's at this point in time, it has to be differentiated from other abdominal lumps like lymphoma, tumors, retroperitoneal lump, and sometimes the pelvic kidney which lies there. And later on, these mesenteric lymph nodes, they develop caseation, forming cystic degeneration. And so then they have to be differentiated from other cystic lesions like mesenteric cyst, abdominal cocoon, ovarian cyst. So what are the causes of lump in abdominal tuberculosis? Now we can find a lump in right leg fossa, and we can find central abdomen because of mesenteric, as I told you, the ilioinguinal region, the psoas sepsis from the spine, the upper abdomen because of rolled up omentum in the derived variety of the peritoneal type, and the lower abdomen because of tubo-ovarian masses. But then anywhere inside the abdomen we can find because of loculated ascites or bowel moving and doing matting of the bowel loops. So as discussed, the presentation is basically chronic, but then we can have episodes of acute presentations also. And these presentations are basically because of the complications. The most common complication being obstruction because of like GI involvement or maybe because of peritoneal involvement. Then the second is presentation of perforation peritonitis. We can have mesenteric lymphadenitis, as I told you, most common in children. These patients can develop massive GI bleed also, but then it is rare. The most common, as far as bleed is concerned, is mild bleed. These patients can also develop pancolitis, and that they have to be differentiated from ulcerative colitis. And rarely discussed, they can present as tubercular toxemia, which is part of the miliary or disseminated type of tuberculosis.
Dr. Yadav, you have a minute more to go.
So I think I can this thing is skip the other organs are basically rarer. So esophagus, the most common involvement is middle 1/3. Esophagus is the next. The stomach, initially the involvement is because of an ulcer, and later on these ulcers, they can develop fibrosis causing gastric outlet obstruction. So then they have to be differentiated from other cause of gastric outlet obstruction, which are more common like malignancy or peptic ulcer disease. Next, sir. The colon, as discussed earlier, can occur with or without ileocecal disease and has a non-specific presentation with colitis or some obstructive features with like Crohn's disease. Next, sir. So anorectal disease is important as this can present as an anal fissure or multiple fistulae, abscess or stricture, and then it has to differentiate from other causes of multiple anal fistulae, which are Crohn's disease or malignancy. And these fistulae, they are not typically, as discussed, typically a single fistulae, the multiple fistulae, and also fissure are not typical fissure posteriorly, they are lateral fissure or a circumflex fissure. The liver, it has rare again, but then it has two presentations, the micronodular, macronodular. Micronodular is the multiple small nodules on the liver surface. The macronodular variety is a large solitary lesion which is seen in the parenchyma. And then they can also present as tubercular hepatitis with fever, pain, and other non-specific features, but the diagnosis is mainly made by the imaging and biopsy. The pancreas, the most common site is pancreatic head, and it has to be differentiated from pancreatic malignancy, acute and chronic pancreatitis, and sometimes pancreatic abscess. The spleen involvement is a part of the miliary or disseminated tuberculosis, and these patients, they are usually immunosuppressed. The patient of HIV taking steroid, transplant recipient, or taking some immunosuppressive drugs. So they clinically present as pyrexia of unknown origin or like splenic abscess with solitary or multiple nodules inside the spleen. So complication I discussed, internal obstruction, most common, perforation 5 to 9% of all cases. Usually the perforation is single, but then we can find multiple perforation like in typhoid. So then you have to take care of, examine the entire bowel. Malabsorption is very, very common, occurs because of intestinal obstruction and then leads to bacterial overgrowth. And then it is because of decreased surface area on decrease for absorption. So causing increase in the unconjugated bile acids, presenting as chronic diarrhea, steatorrhea, abdominal pain, weight loss, and anemia. The fistulation is rare or less common as compared to Crohn's disease, but the pathogenesis is that when the transmural ulcer perforates, forms abscess and leads to fistula formation. The fistula can be internal or external. The external fistula is more common, but the internal also can be ileoileal, ileocolic, and rarely ileovesical. Now, clinically, these patients present with abdominal pain, fever, and sometimes fecal discharge from the previous operated site. And it includes the cause of fistulae like Crohn's, malignancy, or radiation. Now, abscess again is rare, but then it can be serious and it can be localized intraperitoneal abscess, or it can involve the organs like liver and spleen. And then it's caused intraperitoneally by a direct spread from the infected lymph node, or rarely from the GI tract or blood or lymphatic system. The presentation is abdominal pain, fever, lump, weight loss, and we can also have ileus vas abscess, which arises from the tuberculosis of the spine. Hemorrhage is again rare. Generally, these patients, they have mild bleeding, but the massive bleeding is rare. And the cause is because of ulcers in the GI tract, or sometimes the lymph node, they erode to the mesenteric vessels. So they can present as melena, hematochezia, and sometimes when the bleed is massive, they can present as severe shock. So summarizing the presentation, the clinical presentation as discussed is very varied. Now, these patients, they can have very chronic vague symptoms, mimicking other GI diseases. So one has to have a very high index of suspicion to make the diagnosis early and to decrease the morbidity and the mortality.
Thank you, Dr. Yadav. And sorry, I had to hurry up a little bit, but nice, although, yeah. Dr. Preeti?
Thank you, sir. Good
Yeah.
evening, everyone. Today, I'll be speaking on investigations in abdominal tuberculosis. Arriving at a diagnosis of abdominal tuberculosis is very challenging. Hence, we have some criteria which are set up which will enable us to come to a conclusion. The first is the patient should have clinical manifestations suggestive of tuberculosis. This has been described in detail by the previous speaker. Then the imaging evidence, histopathological and microbiological evidence should be suggestive of tuberculosis. And after all these things, if we start the patient on ATT, then the patient would respond positively for the treatment. Next slide, sir. So we'll start with the investigations. The blood investigation will show varying degrees of anemia, leukopenia, and raised ESR. Serum albumin level may be low because it is common in malnourished patients. And in patients with hepatic tuberculosis, the serum alkaline phosphatase may be elevated. As per recent NTP guidelines, HIV test and testing for blood sugars has been made mandatory. Coming to the MON2 test, it is only of supportive evidence because of its limited value due to its low sensitivity and specificity. Coming to the imaging techniques, we can do X-ray of the chest and abdomen. The chest X-ray will show calcified hilar tuberculous lymphadenitis. And when we do an X-ray of the abdomen, we can similarly see calcified lymph nodes. If the patient presents in an acute condition, so we can see dilated bowel loops and multiple air fluid levels, which is suggestive of intestinal obstruction. If the bowel goes for perforation, then we can see air under diaphragm. The next investigation is ultrasound. In the first picture, we can see ascites, which has been aspirated in a syringe, and we can see straw-colored fluid in the syringe. Second, you can see interloop ascites. So there is presence of fluid between the bowel loops, and this sign is called as club sandwich or sliced bread sign. Third picture shows enlarged lymph nodes, which may be mesenteric or retroperitoneal. They may be discrete or matted. Next slide. So here we can see in the first picture, the picture of loculated ascites, we can see thick septa, which is causing the loculation. The second picture shows adhesions between the bowel and the peritoneum, which is called enteroparietal adhesions. The third picture shows bowel wall thickening, which is seen in the ileocecal region. It is that of a terminal ileum. Next. So in the first picture shows thickening of the parietal peritoneum as shown by the arrow. So second picture shows thickened greater opentum, and we can also see hypoechoic nodules. The last picture is called the pseudokidney sign, where there is bowel wall thickening which opposes the mucosal surfaces. This is commonly seen in pulled up cecum. So we can also do ultrasound guided FNAC and biopsy. This is done when there are atypical radiological features or when the patient doesn't have ascites. And even when there is ascites and we do the analysis is not suggestive of tuberculosis. And after starting the patient on a trial dose of ATT, If we don't see any clinical response up to 4 to 8 weeks, then we can do an ultrasound guided FNAC or a biopsy. Next slide. When the patient has ascites, we can aspirate the ascitic fluid and send for analysis, which will show raised total counts with lymphocyte predominance. The protein is elevated, which is more than 2.5 gram per deciliter, and serum ascites albumin gradient is less than 1.1 gram per deciliter, and ADA levels, which is adenosine deaminase levels, which may be more than 39 units per liter. And when we do staining for AFP, which is it is hardly positive in less than 2% cases, and the culture may be positive in only 20% of the cases. CECT is the investigation of choice, and when we are suspecting intestinal tuberculosis, CT enterography becomes the investigation of choice. And the findings would be there is involvement of the ileocecal region. We can also note bowel wall thickening, peritoneal thickening, and there may be presence of multiple nodules in the omentum. Ascites is a common finding. There may be presence of lymphadenopathy. The lymph nodes may be more than 1 centimeter in size. It may be necrotic also. And we can also find pulled up contracted cecum with wall thickening. Next slide, sir. So the first picture shows gross ascites, and we can see the ascitic fluid which is separating the leaves of the mesentery. And the second and third picture shows ileocecal tuberculosis and rectal tuberculosis. Here we can see irregular parietal and bowel wall thickening. We can also see there is a narrowing of the lumen. Next slide. So the first picture shows here thickening of the mesentery with enlarged abdominal lymph nodes. The second picture is that of an abdominal cocoon, which is seen in the anterior abdominal wall. We can also see a layer of membrane which is covering the intestines. Next slide. So this is solid organ involvement. The first picture is that of miliary hepatic tuberculosis. We can see multiple nodules in the parenchyma of the liver. Second, we can see in the spleen that it is studded with nodules. Third picture is that of pancreatic tuberculosis, where the pancreas is enlarged and deformed. The fourth is that of a tuberculoma of the left kidney. Fifth picture, we can see thickening of the urinary bladder as indicated by the arrow marks. And the last picture is that of a adnexal tuberculosis. As I said, CT enterography is an investigation of choice in case of intestinal tuberculosis. However, if facilities are not available, then we can go ahead and do a barium study. So this is useful in more than 75% of the patients. We can do a barium swallow, barium meal follow through, or a barium enema study. So in the first picture, it is of esophageal tuberculosis, where we can see stricture and traction diverticula. Second picture is that of first and second part of the duodenum, where we can see long segment circumferential narrowing. Next slide. We can also do a barium meal follow through and barium edema. The description I'll explain with the pictures, sir. So next slide.
Okay.
Yeah, in the first image, we can see hypersegmentation of the barium, which is called as chicken intestine. The second picture shows pulled up cecum, which is conical in shape, and we can see that the ileocecal angle is obtuse. The third is called the gooseneck deformity, where the ileocecal valve is abnormal, and you can see dilatation of the terminal ileum, which appears to be hanging from a retracted and scarred shortened cecum. In the third picture, we can see multiple strictures, and in between, we can see the segmented bowel loops. Next slide. There are few signs which are important. So the first is called the Fleischner's sign, and we can see in the diagram there that the ileocecal valve is deformed, it is thickened, it is triangular in shape, and also the terminal ileum is narrowed. The second image is called the Sterling sign. Here there is inflamed segment of the small bowel, so there is rapid transit and lack of retention of the barium in the bowel. That is called the Sterling sign. Next, we have the string sign, where there is narrow terminal ileum. So we can only see a narrowing of the stream of the barium. That's called the string sign. Next investigation in intestinal tuberculosis is colonoscopy. So here we can see mucosal nodules, edema, transverse ulcers. We can also see strictures and occasional diffuse colitis. We can note that the ileocecal valve can be deformed or it may be totally destroyed. The commonest site of involvement is found to be in the ileocecal region in about 32% of the cases. So we have some colonoscopic pictures in the next slide. So here we can see mucosal edema. There's a lot of ulcers. A mass can be seen, and we can also see that the ileocecal valve is deformed. Next slide. When all the above investigations are not able to help us with the diagnosis, as a final resort, we can go and do diagnostic laparoscopy. The advantage is here we are directly visualizing the inside of the abdomen, which will help us in making a diagnosis in 80 to 90% of the patients. We can also take a biopsy, which will reveal AFP in 75% of the patients, and we can see granulomas in about 85 to 90% of the patients. So when we can see inside, we can see that there is thickened peritoneum. We can see ascites here. We can see fibrous adhesions. Next slide. And we can also see that the parietal peritoneum is studded with tubercles. There is omental adhesions in the image C. And in all the pictures, we can see multiple nodules. So in colonoscopy or in diagnostic laparoscopy, we take biopsies, and this is sent for histopathological examination. So here we were able to demonstrate granulomas in 50 to 80% of the cases. These granulomas contain epithelial macrophages, Langerhans giant cells, and lymphocytes with a central caseating necrosis. Next slide, sir. Lastly, we need to have a microbiological confirmation. So for this, the NTAP has approved the NAT test. The NAT stands for Nucleic Acid Amplification Test. There are Gene Expert MTB-RIF, which is a capsule-based NAT, which is called the CB-NAT. And we also have a true NAT test, which is a chip-based. So both of this help in detection of tuberculosis and rifampicin resistance. We also have a line probe assay, which uses PCR and reverse hybridization methods to detect gene mutations associated with drug resistance. Next, we can do direct examination by using ZN staining or fluorescent staining. We can do culture of the tubercle bacilli using LJ medium or automated liquid culture systems. The other modalities we have already discussed, the tissue biopsies, ascitic fluid analysis, and the radiological examination. There are some tests done to detect the drug susceptibility, which is the phenotypic DST and the molecular DST. So to summarize, when we are suspecting abdominal tuberculosis, this is a flowchart which we can follow. If you are suspecting peritoneal tuberculosis, we can go ahead and do ultrasound, ascitic tapping, and send for analysis. In cases of gastrointestinal tuberculosis, we can do CT or MR enterography. We can do colonoscopy, take biopsies, send for histopathology, microbiology. And if the above CT facilities are not available, then we can do a barium study. Coming to perianal TB, as already discussed, it is not very common. However, the clinical suspicion should be kept in mind, and we can do an endoanal ultrasound and take a biopsy. Pancreatic and hepatobiliary tuberculosis, again, it is rare, but malignancy should be ruled out as a priority. We can do endoscopic ultrasound, take a biopsy, and send it for histopathology. If all this is not helping, we can finally go ahead and do a diagnostic laparoscopy. In spite of having such a big armamentarium of investigations, in spite of it, it sometimes becomes very challenging to make a diagnosis of abdominal tuberculosis. Thank you, sir. Thank you, everyone.
So, thank you, Preeti, for being on time.
Thank you, sir.
Dr. Hemanti,
Good evening, sir. Am I audible, sir?
you're loud and clear, madam. Thank you. Please
Good
go ahead.
evening, everyone. At the outset, I would like to thank the ASI for giving me this opportunity. Continuing with the treatment of abdominal tuberculosis. So, next slide, sir. There are two categories of patients where ATT is initiated. One is the definitive abdominal tuberculosis who have the histologically or microbiologically proven diagnosis. And the second category is the clinically diagnosed abdominal tuberculosis, where we start a trial ATT based on the clinical or radiological picture, although there is no definitive evidence. In both, the ATT regimen is as per NTAP guidelines, that is 2 months of intensive phase with 4 drugs, INH, rifampicin, pyrazinamide, and ethambutol, and 4 months of continuation phase with 3 drugs, that is INH, rifampicin, and ethambutol. Baseline LFTs must be done before starting treatment, and if it's normal, it should be repeated at monthly intervals. If the baseline LFT is abnormal, suggesting any pre-existing disease, it should be repeated weekly, especially during the intensive phase. Next slide, sir. Now, the main challenges we face after starting ATT are, the first thing is deciding the duration of treatment. Multiple RCTs have addressed this question and have proved that 6 months is adequate for abdominal tuberculosis, with certain exceptions like the pancreatic or hepatobiliary tuberculosis, which needs 9 months or more, conditions like associated immunocompromised HIV positive, or if there is comorbidities like CLD, CKD, where drug dose needs to be modified, or drug-resistant tuberculosis cases, or in cases where patients are non-compliant, or if there's any interruption of treatment, or if it is a recurrent case in patients who already used ATT. These are all the scenarios where the treatment should be tailor-made and decision should be taken based on case. The next question to be addressed is how to decide whether the treatment response is adequate and what is the end point of treatment. Here, 3 key points must be kept in mind. The first thing is paradoxical reactions, which is nothing but body's exaggerated immune response to the antigens released from the dead bacteria. This can present as increased ascites, increased size of lymph nodes, fever, etc. And the second point is the disease sequelae, which may be in the form of peritoneal adhesions, intestinal strictures, which can persist even after the active disease regresses, and they may be symptomatic. The third, overlapping symptoms of adverse drug effects like abdominal pain, nausea, vomiting, or a decreased appetite, which may be because of a drug-induced gastritis or hepatitis, may cause a confusing picture. So all these must be kept in mind while assessing response. And if your patient, so next slides. If your patient shows a clear objective response, like in this case, showing a healed ulcer on colonoscopy, not only the patient, even the surgeon is lucky. Now the next slide. So going to the guidelines for response assessment, it should be considered in every patient, but especially it is mandatory in those which once we start the treatment on a trial basis, if they are clinically diagnosed. And objective response criteria like ulcer healing on endoscopy, ascites resolution on ultrasound, or disappearance of radiologic lesions are preferred over subjective features like weight gain or sense of well-being. Lack of response could be due to misdiagnosis, especially when we start a trial ATT, or it can be due to drug resistance. This should be considered in definitive cases, or it can be like a sequel of tuberculosis, which we already discussed. So when to assess response? 2 months is a reasonable time to assess response because these are superficial lesions and we expect early mucosal response in 2 months. The role of biomarkers like fecal calprotectin is being evaluated. Next slide. So the interesting topic for surgeons, what are the indications for surgery? Majority are emergency indications like when the patient presents with acute intestinal obstruction, perforation, or massive bleeding. Or sometimes we go for elective laparotomies when the patient has persistent symptoms or recurrent episodes of subacute intestinal obstruction due to an underlying ileocecal mass, stricture, or cocoon abdomen while on ATT, or cases of fistulizing intestinal tuberculosis which don't heal with ATT. As already Preeti Madam discussed, diagnostic dilemmas, or occasionally it may be an incidental surprise when you open the Pandora's box for some other reason. Next. So the intestinal obstruction, the causes as already discussed by Yadav sir. We'll proceed with the next slide where we see the management of the commonest form, that is strictures. A study conducted by Jenna et al., a meta-analysis published in the BMC Gastroenterology, gives an interesting analysis. The response of the stricturing disease to ATT, in 77% of the cases, they show clinical response, that is symptomatic improvement. In 66% cases, show stricture resolution, which is evidenced on endoscopy. For the non-responders, 14% can be dealt with by balloon dilatation, whereas 21% require surgery. Which strictures are poor respond to ATT? So the colonic strictures, when compared to the small bowel strictures, are poor responders. The long strictures, which are more than 3 centimeters long, and obviously the multiple strictures. So what to do? The role of endoscopic dilatation is confined to only short strictures, which can be accessed on colonoscopy. So the picture here shows, the next picture here shows the colonoscopic picture, where there is a stricture in the terminal ileum and another stricture in the colon. Both are dealt with by balloon dilatation, and the lumen was good after 2 sessions. The role of surgery for stricture. A stricturoplasty can be done when the stricture is isolated and it is not associated with any mass lesion or perforation. A resection can be done when there is a long tubular stricture, or when there is an associated mass lesion, or when there is a diagnostic dilemma. A resection with stoma is preferred when the stricture is associated with perforation or sepsis, or when the patient's general condition is poor. When there are multiple strictures, the main stricture can be dealt with by resection, whereas the other strictures can be dealt with by stricturoplasty. The next slide. So this picture shows the technique of stricturoplasty. In this, the most important thing to be kept in mind is to remove a small ellipse of tissue along the long axis for biopsy. This is mandatory, and the lesion should be closed transversely with interrupted sutures. So this is a common picture at laparotomy. We can find extensive peritoneal tubercles, which is a characteristic feature of the disease, and it is not a contraindication for any form of surgery on the bowel. So extensive peritoneal tubercles is not a deterrent for primary anastomosis. The ileocecal mass is the next common presentation which we come across, and here we prefer the conservative surgery over a radical right hemicolectomy. And during this resection procedures, the challenges encountered are dense adhesions to the retroperitoneum, interbowel adhesions, shortened pulled up cecum, and most importantly, the identification of ureter may require some time. It may be encased in the retroperitoneum. So this picture shows the segmental resection for ileocecal mass, and we can observe the proximal resection limit is the terminal 8 centimeters of the terminal ileum, whereas the distal limit is just beyond the disease. So next. So the next is the abdominal cocoon. So the surgical principles here are a complete excision of the membrane by sharp dissection with the Mayo scissors and minimal manipulation of the bowel, with starting adhesiolysis from the intermesenteric adhesions and proceeding towards the interbowel adhesion. So whenever we encounter any obstruction or any perforation, better to proceed with the proximal enterostomy rather than dealing too much with the adhesions and trying to separate and causing an iatrogenic injury. So as Dr. Yadav already covered, so it can be either a complete cocoon or a partial cocoon, but in both the conditions, the principle remains the same, a sharp dissection and clearing the entire membrane. Usually in these cases, the bowel disease is not due to the tuberculosis, it is due to the mechanical restriction of the space causing thick edematous bowel loops. Perforation is the other dangerous complication of this condition. Here we need to be careful to counsel our patients regarding the high risk of mortality. Most of the perforations are ileal and proximal to a stricture. If the perforation and stricture are nearby, then we can go for a resection. If they are separated far apart, and if the surroundings of the bowel surrounding the perforation is healthy, then that can be closed in layers and the stricture can be dealt with by either stricturoplasty or resection. Following resection, a stoma is preferred over primary anastomosis in view of the fecal peritonitis and sepsis. Next slide. So this is the picture showing a perforation with a distal stricture beyond that. Next slide. For the fistulizing intestinal tuberculosis, as already covered by Dr. Yadav, multiple types of fistulas can be there, and the treatment is again ATT is the first line of treatment. The indication for surgery is only for persistent fistulas after ATT or fistulas associated with sepsis or abscess. So here the fistula excision need to be done along with the underlying diseased bowel segment to avoid recurrence. And following any surgery for abdominal tuberculosis in the postoperative conditions also, we can encounter sometimes the EC fistulas. The management is similar to any other EC fistula, plus immediate initiation of ATT, and definitive management can be delayed until the completion of ATT regimen. Massive GI bleeds are rare, and preoperatively it's difficult to localize. Maybe localization can be done at laparotomy, looking at the disease surrounding the bowel segment, and that segment of bowel need to be resected. Sometimes it may be an incidental surprise when you open the abdomen for some other condition. If you encounter an acute tubercular peritonitis or mesenteric lymphadenitis, if frozen section is available, proceed with frozen section. Ensure that take an adequate targeted biopsy, do thorough peritoneal toilet, and close the abdomen without drains. Postoperatively, ATT can be started as early as the patient tolerates. Madam already covered this, the indications for diagnostic laparoscopy. And in laparoscopy, the challenge is in putting the first port because of the multiple adhesions which may be there, and also the limited expansion of the abdominal cavity in peritoneal tuberculosis. The caution is to ensure adequate tissue for analysis and to minimize the use of energy sources to avoid cautery artifacts, and proper handling of the specimen and sending it in proper solutions. Next. So overall, the surgeries for abdominal tuberculosis can be of 3 types. The first is the bypass procedure, which is enteroenterostomy or an iliotransverse colostomy, which appears simple, but it should be avoided because it is associated with complications like blind loop syndrome, fistula formation, and recurrent disease in the remaining segments. The radical procedures like right hemicolectomy are also not ideally preferred because these patients are poor surgical candidates in view of their malnourished status. And if the bowel lesions are widely placed and if we resect large segments of bowel, especially if these people require a reoperation for recurrent obstructions, then it may result in short bowel syndrome. So the conservative procedures are preferred procedures. These include the stricturoplasty, the segmental ileocecal resection, or a limited resection of the involved segments with primary anastomosis. The postoperative complications include anastomotic leaks, fecal fistula, peritonitis, intra-abdominal sepsis, wound infections, wound dehiscence, a persistent obstruction which may even require a recurrent reopening. Recurrent obstructions may require laparotomies. So the mortality rate is 4 to 12%. A delayed diagnosis and injudicious treatment are the main culprits for this high mortality, but it may be partly also due to patient factors like malnutrition, anemia, and hypoalbuminemia. It is especially high in case of acute complications. So to conclude, abdominal tuberculosis is basically a medical condition. Early diagnosis and appropriate drug therapy is the key. The role of surgery is largely limited to emergency conditions, which constitute 20 to 40% of the abdominal tuberculosis. Surgery is mainly to tackle the emergency rather than removing the macroscopic disease, which is unnecessary. So in case of absent preoperative histological diagnosis, take multiple targeted biopsies to improve the diagnostic yield, because you don't want to have a punch in your face when your patient returns with his biopsy report, which reads inadequate sample, advised repeat biopsy. Thank you, sir.
Thank you, speakers. So now we are open to question answer sessions. Hello? So
You're very much audible, sir. You're very much audible.
Yeah. So we have finished.
I'm sharing. Do you have any more slides?
No, the over, sir. The rest is all concluding.
So I'll just stop sharing these slides so that we can see each other better. Yeah, okay.
Yeah, Dr. Noor, there is a few appreciations of your moderation as well as your all the faculty. That is the first thing I'd like to tell. There are one or two questions have been asked. Any role for a LDH to ADA ratio in abdominal fluid? I think investigation comes, Dr. Preeti.
Dr.
I
Preeti,
think LDH to ADA ratio. Hello.
Dr. Preeti?
I think with the advent of
The ADL levels are elevated in ascitic fluid analysis.
So I think what I understand is that we do get this because conclusion slide, Madam has put the first slide that it is a medical, medical whatever. I personally believe that surgical books give extensively also about the about the tuberculosis, abdominal tuberculosis, and often these people are investigated with all these things, SAG to everything,
ADA.
sputum to everything, and yes, ADA, everything. So they're non-specific according. So only tissue diagnosis, I think, is very high microscopy or biopsies, etc., etc. There is one more question on this cocooning. Yes, removal of those membranes. That some difficulties, any difficulties, and any experiences, and every abdominal cocoon, is it a tuberculosis or something else? Yes, who will be taking that?
I'd like
This
one
is a
of my
question,
speakers
Noor.
to, yeah.
Please go ahead.
Yeah, actually, cocooning, as mentioned earlier, it's basically a form of severe fibrocollagenous reaction that is there in the body. And it's also known as sclerosing encapsulation peritonitis. As also mentioned, it can be partial or complete. Apart from tuberculosis, there are many other diseases like when
Yes.
you have prolonged usage of propranolol and the continuous ambulatory dialysis, then presence of ventricular peritoneal shunts. And these are some of the conditions where you have a very similar looking condition. So many a times, unless you have a tissue diagnosis in place, it's very difficult when you enter in to know whether it is tuberculosis or otherwise. But of course, what sometimes helps is in the cocoon, when you see multiple areas of tubercles, that sometimes give you a hint that yes, it may be a case of abnormal tuberculosis. But as far as surgery is concerned, it's a challenging surgery. And the cornerstone of treatment in this is if you are using any dissection, it is always a sharp dissection that may help you. And injuring the bowel loop is very, very common. And many a times you end up doing a stoma, and sometimes even an ileostomy or even a much higher stoma may need to be created. Definitely a difficult problem to treat surgically.
I would like to add one point. While doing this sharp dissection, I think our finger palpation is also very important to differentiate whether it is a fibrotic tissue or it's a gut. So just doing the sharp dissection and doing injury to the gut sometimes create a problem. So feel of that particular bowel is also very important.
Yes, I think Ajay Tukral, I would say it is touch and cut.
Touch and cut.
Yeah. Because sometimes the temptation is to do finger separation, which is not exactly a very good idea.
No.
You end up having multiple serosal tears.
Yes. You're absolutely right, sir.
Often, this one from my side to
Sure.
and that's you have a high index of suspicion, stricture, you section and send maybe a single stricture, no lymph node. The report comes as no caseation granuloma sometimes, then no concrete evidence. So what is your take? I think some empirical issue has been raised. What is your take in
I
this?
would like Dr. Preeti to try and answer that.
So we can start a trial dose of ATT if the clinical suspicion is high and if radiological or other investigations are supportive. But however, if biopsy is not confirming, we can give a trial dose of ATT for 4 to 8 weeks and then
I think,
maybe
Preeti, the other thing that can also be done, instead of straightway starting ATT, when you send the tissue, we send the tissue usually for histopathology. You can also send a bit of tissue for genetic assay also. Genetic testing, molecular testing. Because if you can get
into SCP NAT.
one of them positive, that is fair enough to start ATT, because in our scenario where the incidence of tuberculosis is very high, I think at the slightest indication that one of the newer molecular testing has shown the NAT positivity, based on that you can actually start rather than empirically start without these tests. Of course, availability of this test today has become quite common. And I think that is also the recommendation that the National Tuberculosis Eradication Program is talking about. More and more usage of the NAT testing.
So that's, I think the equally important is MDR and rifampicin resistance and all, no? That also, so.
Of course, yes.
And so may I add one thing about granulomas?
Sorry.
Okay.
It is said that granulomas, if it is more than 200 micrometer in size and confluent, they suggest tuberculosis. And if they are less than 200 micrometer in size and less confluent, then they are suggestive of Crohn's disease. So maybe I can help. Size of the granulomas and confluency. If a good pathologist can help us.
Dr. Prabhu wanted to make a comment. Dr. Prabhu.
Yeah, it's in fact excellent presentation by all of you, and of course, such a topic which is controversial and it's absolutely massive, huge. A couple of, in fact, I need to ask some doubts. One of the doubts, as Dr. Shinoy said, we very often face that you take a biopsy from a small stricture and do a stricturoplasty, and it comes out as a non-specific thing. So should you give anti-tubercular treatment or not? That's one. Number two, often we get cases of cocoons. Cocoons, when you take out the membrane, the bowel is absolutely healthy. My dilemma is, should you give anti-tubercular treatment or not? That's the second question. And the third question is, one of the speakers talked about empirical treatment of ATT. Is that recommended now? What is your take on all these three questions?
Dr. Hemanti, I think you are most suitable to answer that.
Empirical treatment is recommended by NTEP guidelines only, sir. We call those clinically diagnosed abdominal tuberculosis cases, and the same regimen is advised for them also. But response assessment is must in these cases, both endoscopically or by ultrasound. Objective assessment is must.
Madam, just I know the what you said recommend. I have one, because see, endoscopically assessment. See, it's a little difficult task. Right. We are talking about colonoscopy and probably then looking into the ileum, healing of the ulcers.
That's why when I showed the picture, I said both the surgeon and the patient is lucky if you get such a picture where response is obvious.
Question, after the cocoon excision, would you start an ATT?
Yes, sir. When there are no other conditions like already discussed by Dr. Yadav and Dr. Noor, sir, the other conditions which are responsible for this sclerosing encapsulating peritonitis. So we consider definitely it must be due to tuberculosis, and we can go for an ATT. Again, clinically diagnosed category.
Madhuga wants to ask.
Yes, sir. I can have a question. Like, as it tuberculosis is very common in the area where I work in. Like, I've seen all forms of abdominal tuberculosis that have been spoken of, and say like between these 20 to 40 years age group, the intestinal obstruction. As you all have said, is around 20%, but I think at least 40% are due to abdominal tuberculosis. My question is that what do you do? This is often a dilemma which we face, that empirical ATT has been given, or maybe a proof diagnosis and ATT has been given. The patient comes after 6 months with a typical still features of intestinal obstruction. Maybe features are still there are CT features or USG features are still persisting. Maybe a little lowering of the symptoms, but it's still there. Now, what do? You continue give 3 more months of ATT, or you go for some surgery?
Madam,
At that
this is the challenge I discussed, what we call the disease sequelae, which can be, the symptoms here can be due to persistence of peritoneal adhesions or due to persistence of intestinal strictures. So these sequelae need not be always dealt with unless they are very troublesome to the patient, like causing recurrent attacks of intestinal obstruction. Then only
Absolutely.
they should be dealt with.
Okay.
I have a small thing related to this, madam. ATT treatment and 6 months completion, going in for some kind of an obstruction. Also, few patients who, what is happening is slowly they will modify their diet, because this is my observation. What happens is the lumen is slowly getting narrowed, may not be total narrowing. So they are under follow-up of whoever it is. Then what happens is the patient try to adjust their food. In fact, if you carefully ask this question, because you mentioned somewhere weight loss is somewhere you mentioned subjective or something, but definitely there will be a increasing weight loss is an indirect indication of a truly obstruction. Patient may not have the classical that, the step ladder peristalsis and all that thing, but lumen is slowly getting narrowed and patient is fearing to eat, actually, is afraid. Probably this is what I think goes for a clinical decision for a resection, my opinion.
I think in situations like this, and especially when you are dealing with few strictured areas, now I think the point to remember is these strictures are very common in the terminal ileum area. And when you look at of course, every part of bowel is important, but when you look at the importance of the terminal ileum in terms of, the intrahepatic circulation of bile acids and other things, it's a very important area. So resection in that area is to be avoided, and as madam has mentioned that surgery should be more of conservative surgery. So here, instead of resection, depending on the number and the distance between the two strictures, if they are multiple, we should ideally go for stricturoplasty again. Yeah.
A lot of discussions have come in, but time is closing up. Can I request Dr. Gadi Diwakar to make some comments?
Yeah, thank you, sir. Good evening, everyone. On behalf of the Association of Surgeons of India, I extend my sincere gratitude to our esteemed moderator, Dr. Noor Topno, for conducting this session with clarity and academic depth. I express my heartfelt thanks to our distinguished panelists, Dr. Hemanti R., Dr. Ajay Thakral, Dr. Alvel Singh Yadav, Dr. Preeti SP for their valuable insights and enriching contributions to this important discussion on abdominal tuberculosis. As Dr. Noor Topno mentioned initially, TB is a greatest mimic. There was a time during our post-graduation times when no diagnosis fits it, then think about tuberculosis. And as a corollary to that, tuberculosis used to be a differential diagnosis in every disease. But the scenario is changing, and this has been amply clarified by this webinar. I take this opportunity to thank our President, Dr. Maruthu Pandian, Dr. Pratap Sinavarate, Vice President ASI, Treasurer Dr. Madhumita Mukhopadhyay, Dr. Prabol Niyogi, Director of International Affairs, Dr. Rajgopal Shanai, Director for Academic Council, and I also thank the main architect of these programs, Dr. Santosh John Abraham sir, and also I thank Dr. G. Siddesh sir, Director for Social Welfare Council. And such academic deliberations strengthen our collective knowledge and ultimately benefit patient care. Thank you all once again.
Thank you very much, Dr. Gadi, for the final words of thanks, Dr. Madhumita. Honorable question.
Thank you, sir. Thanks to our President, Dr. Maruthu Pandian, our Vice President, Dr. Barute, our past president, Dr. Probal Nyuki, for all your valuable inputs. Thanks to our academic advisor, Dr. Santosh John Abraham, who is the real architect behind the whole program. Thanks to Dr. Shinoy, our academic director, for bringing out such a wonderful program. Thanks to Dr. Noor Tokno, of excellent moderation. Thank you, sir, so much. And it's a very important topic. Thanks to all our presenters, very good presentation and a very good time management. Thanks to Dr. Hemanti, Dr. Ajay, Dr. Yadav, and Dr. Preeti. Thanks to Dr. Gaddi Divakar, our very hardworking secretary. Thanks to all our viewers who have been watching these programs. Thanks